Hey guys, welcome to the Chapter 19 lecture. This is all about diseases of the respiratory system. This is just that handy-dandy image from the textbook that is sort of a summary slide and tells you all about the different diseases, an overview of the different diseases we're going to be discussing in this chapter, and also breaks them down based on whether they are bacteria, viruses, or fungi, or something else. So in this chapter, those are the three types of microbes that are the primary infectors of the respiratory tract. So before we can talk about the disease of the respiratory tract, a quick overview of the structure, anatomy of the respiratory tract, and its defenses. So the respiratory tract includes the nasal passages and even the oral passageway, the nasopharynx back here in the throat, the pharynx, and then air that you breathe in goes down the trachea, which is the windpipe, and then the trachea here branches into two branches called the bronchi. The bronchi branch into smaller branches called the bronchioles, and at the end of the bronchioles there are the air sacs, the alveoli, and that's really the important part of the respiratory system, the alveoli, which is where gas exchange actually occurs. Oxygen goes into the blood and carbon dioxide leaves the blood so you can exhale it. The rest of the lungs, the lung tissue here, there's 3 lobes of the right lung and 2 lobes of the left lung. It's just basically a soft spongy tissue that's there to support and protect all of these bronchioles and the alveoli. The trachea, the bronchioles, all of those are lined with cells that are ciliated. So they have these little, cilia is actually I think Greek or Latin for eyelash. So it has these little eyelashes, just like your eyelashes help keep material out of your eyes. The cilia help to catch, trap, and move particulates out of the respiratory system. You also have mucus producing cells that produce mucus, and the cilia help to move that mucus up and out as well. So, and the mucus, of course, will contain things like IgA, secretory antibodies. There are macrophages within these cells built into the tissue, into the lung tissue. There's other antimicrobial proteins. There's the mucus. There's the hair in your nasal cavity that helps to trap things. So there's basically a system of physical and chemical traps that then help to, and then a system to move things out. That system, by the way, is called the mucociliary escalator. It's kind of like an escalator. And so, all those things help to protect our respiratory tract. But of course, our respiratory tract is vulnerable because it is open to the outside world. We are constantly breathing in things from the outside, so it does make it a very good portal of entry for potential pathogens as long as they can evade these other defenses. So because it's open to the environment, it is also, there's so many bacteria and fungi that we breathe in all the time that some of them do colonize our respiratory tract and live there as commensals, as normal flora. We'll see a theme, and that we've sort of a running theme in this unit, is that normal flora, although they can be normal and harmless, can also still get into parts of the body and cause disease. So Streptococcus pyogenes is one we've already talked about that can cause skin infections, but it can also cause the common strep throat. And it can be a normal flora. There's a lot of people who carry this bacteria and it doesn't cause disease. Haemophilus influenza, specifically Haemophilus influenza B, or Hib. We have a vaccine for that now, so probably not a lot of natural carriers around, but before we vaccinated for it, it was a normal flora that also occasionally caused really serious disease. Strep pneumonia, Neisseria meningitidis, both of these are causative agents of meningitis, and we talked about them both being normal flora. So another one is Candida albicans, which we commonly just refer to as yeast when we talk about like a yeast infection. That is Candida albicans. It's a type of fungus, and it's a normal flora. It can colonize the mucosal surfaces, particularly the mouth, the oral, and the vagina. Some fun facts for you, people who have different environments of their lungs will have different microbiota, and that kind of makes sense ecologically. So people who are smokers versus non-smokers, they're finding that they have totally different microbes that colonize their respiratory tract. So we know that the upper respiratory tract, the nose, the mouth, the throat, are all definitely well colonized with common bacteria. What we don't have a good grasp on is what bacteria, if any, colonize the lower respiratory tract. So the trachea, the bronchioles. It's not clear whether there are normal flora down there or whether it is a sterile environment. So it's difficult to get samples for doing stuff like the human microbiome research, because that would require invasive techniques to get those samples for this data mining project. So typically for the human microbiome project, the areas that we're studying are areas that are simple and easy to sample, surfaces basically. Alrighty, so let's talk about the first disease of the respiratory tract. We'll start in the upper respiratory tract and move down. So pharyngitis, super common. Basically, we call that a sore throat. So a red, inflamed sore throat, pharyngitis. And it can be caused by a number of different pathogens. But the ones that we're going to focus on are the ones that are the most common. So there's a whole bunch of different viruses that can cause sore throat. A lot of times a sore throat is sort of the part of the prodromal phase before like an upper respiratory tract infection, like a sinus infection or a head cold, right? But the ones that cause that's their major disease is Streptococcus pyogenes, which is strep throat. And it causes a lot, basically most bacterial cases are that. But there's another bacteria that causes inflammation of the throat called Fusobacterium necrophorum. And this one is more opportunistic, so this one is not necessarily super common, but is more common than people often realize. So you can get pharyngitis from non-infectious agents, just from irritation. You can have inflammation of the throat from, shouting too much, or talking, singing, shouting too much can all cause inflammation of the throat, or it can be due to an infection with a bacteria or virus. Fun fact, the sore throats that are caused by bacteria are usually more painful than those caused by viruses, so that can be one clinical sort of symptom or telltale sign that you have a bacterial infection rather than a viral infection. Also, those that are caused by bacteria are more likely to be associated with a fever and other symptoms. So let's look at strep pyogenes or strep throat. So Streptococcus pyogenes is a gram-positive coccus, and it is a very common infection, particularly in childhood, causes that sore throat, and the treatment is antibiotics. Flip over here, all right? The treatment is usually a penicillin or amoxicillin or someone who's in the penicillin family, though there's other drugs if people are allergic to penicillin. But the reason that sometimes it's self-limiting, like sometimes if you don't treat it, it will go away. But the problem is you don't want to take the risk of potential sequelae or complications of strep throat. And those include scarlet fever and rheumatic fever. So scarlet fever is due to a certain strain of Streptococcus pyogenes, a strain of Strep pyogenes that has been infected with a bacteriophage and has basically acquired a special toxin. And this is called pyrogenic exotoxin. It's a toxin that it secretes that causes fever. And so that's what scarlet fever is. You also get a sandpapery rash on the body and this pattern on the tongue that's called strawberry tongue because it makes these little dots on your tongue that make your tongue look like a strawberry. And of course, a fever. And so scarlet fever, no fun. Rheumatic fever is particularly dangerous because this is due to a cross reaction that your immune system creates towards one of the strep proteins that happens to look a little bit like a protein in your heart muscle. And so your body starts making antibodies to the strep protein, but those antibodies are cross-reactive, meaning they also recognize the heart muscle and bind to it and cause damage to the heart. So rheumatic fever can cause permanent, lifelong heart damage. So there's so many different types. There's 80 different serotypes of strep pyogenes. And the immunity that you have to it is serotype specific, which is why you can get strep throat multiple times, because what you're getting is basically a different strain each time, or a different serotype. So, and when they test for it, when they test for strep, they're usually doing a rapid diagnostic test these days. These are kits you can actually buy on Amazon. I usually do this in lab, where I have a culture of strep and I pretend like it's somebody's mouth, and all the students come and swab it and do a rapid strep test. And it's one of those lateral flow tests, like a pregnancy test or a drug test or a HIV test. And one line is negative, 2 lines is positive. And this is a test that can be done in a couple of minutes in the office. A lot of doctors' offices will follow up that with a culture test, which is more definitive, where they actually culture the bacteria on a petri dish and look for antibiotic sensitivity. So that's why because there are a lot of false negatives, if you just don't get enough antigen on that swab, you may get a negative result in the rapid test, and so to follow it up with the culture is just good practice. So this culturing doesn't distinguish between those different serotypes of strep pyogenes. So the doctor doesn't know if it's one that could potentially cause scarlet fever or rheumatic fever. It doesn't matter in terms of treatment, because all of those strains are susceptible to the same antibiotics, but it's not wise to not treat strep because of that fact. So some of the virulence factors that allow strep pyogenes to make us sick is that it is resistant to lysozyme, which is also why it can colonize us pretty easily. It has special fatty acids that allow it to stick really well to things. That M protein, that also happens to be the one that's cross-reactive with the heart muscle, it allows the bacteria to resist phagocytosis, so it can get past innate immunity because it basically, I don't know, tastes bad to phagocytes. That's how I'm going to anthropomorphize this. It also has some enzymes that help us with diagnostics. So there's an enzyme called streptolysin, which lyses red blood cells, and it'll do this on blood agar when you grow it on sheep's blood agar. And so it's one of the definitive ways to culture and identify strep pyogenes, to look for that hemolysis, the lysis. So when you grow it on sheep's blood agar, which is red, wherever the bacteria is growing, you get like clear zones in the agar because it lyses all the red blood cells. But it also damages red blood cells in the body, can cause problems, especially if it gets into the blood. And it also secretes an erythrogenic toxin. Erythro means red. That's what causes that rash in the case of scarlet fever. So we know how to diagnose it. We can treat it with antibiotics so far. I don't think there are any significant numbers of antibiotic-resistant strains of strep pyogenes, so that's good. It's still very treatable. And prevention is just through good hygiene. There's no vaccine for it. And it's a fairly mild infection and very treatable, so I'm not sure there is any market for vaccine development. What I also will mention here that I don't have on the slides is that a lot of times, a lot of students will tell me, well, I had strep a bazillion times when I was a kid, and they took out my tonsils. So the reason that a lot of tonsillectomies are done is because strep pyogenes, it causes inflammation of the throat, and the tonsils are immune tissue of the throat. And so when you have a throat infection, the tonsils become very inflamed and swollen, just like your lymph nodes will. But the tonsils being in the back of the throat, when they're very swollen, it can also cause like breathing problems. It can cause significantly worse pharyngitis, and can cut off sort of the back of the throat and can be dangerous. So very swollen tonsils can be dangerous. And so A lot of times kids who get repeated strep throat infections will have their tonsils removed to prevent that sort of side effect of strep. Another bacteria that can cause pharyngitis is called Fusobacterium necrophorum, and it is a gram-negative bacteria, unlike the gram-positive Streptococcus, and it can cause a really serious form of pharyngitis, usually in immunocompromised, people who are slightly immunocompromised, but most of the cases that occur are in adolescents and young adults. The problem with it is that there's a serious sequelae. It can enter the bloodstream and it spreads to other organs and causes basically disease of these other organs. That's called Lemierre's syndrome, which is a really life-threatening condition because it's attacking multiple organ systems. And strep screenings will often miss this because they're checking for strep and for gram-positive bacteria. And if they're not doing a gram stain, they're just culturing it, which is what they usually do, they may not get any growth, and they may say that it's just a viral pharyngitis when in fact it's caused by Fusobacterium necrophorum. And it is sensitive to antibiotics. It is treatable, but not with the penicillin drugs, the class that treats Streptococcus, with different family of drugs. So it's something to sort of have in the back of your mind, especially if you are a teenager or a young adult, which many college students are, and you get a really bad sore throat and it's strep negative, it might be something to mention or throw out there. I don't know anyone who's had it or been confirmed for it, but it's, a good thing to know about. All right, now for another type of upper respiratory tract infection that's really common is the common cold. So there's several different viruses that can cause the common cold, which is why it's so common and we get it so often. We might have some immunity to, some of the strains of common cold, but there's so many out there that you can get the cold several times by different agents. So the two most common types of viruses that cause the common cold are rhinoviruses and coronaviruses. So this is an image from an old textbook of mine that was like a mnemonic to help you remember. So it's a rhino with a cold, and he's holding a corona, and the NyQuil is for the cold. So you can remember rhinoviruses and coronaviruses are the biggest causes of the common cold. So this is where, with the current coronavirus outbreak in COVID-19, there's been a lot of misinformation about, oh, coronavirus, it's just the common cold, it's no big deal. There are several strains of coronavirus that cause the common cold. The problem is that there have been a couple of strains that have jumped the species barrier in the past decade or so that have caused more severe disease than the common cold. So the current coronavirus, the SARS-CoV-2, is not your common cold. It is related to viruses that cause the common cold, but it is not the common cold. And that's sort of similar to things like E. coli. There's tons of E. coli species that live in our guts and are perfectly harmless and are commensal flora. And then there are species of E. coli that have acquired new toxins and cause very serious deadly disease. So just because one species or strain of a microbe is harmless doesn't mean that there are not other strains that are harmful. And so that's the coronavirus for you. There's some other viruses that cause common colds as well. Transmission can be direct through droplet contact, and it can be indirect through fomites, like you sneeze on tissue and then drop the tissue on the floor, pick up the tissue, somebody else picks up the tissue, and they get your germs. We all know the symptoms: sneezing, coughing, runny nose, stuffy nose, scratchy throat, all those things, sometimes a fever, sometimes not, and are classic symptoms. Sinusitis is inflammation of the sinuses. These are in the face. These are cavities that can fill with fluid when you get sick. And then that fluid causes this pressure in your face, which can cause like pain in your eyes and your nose and your head. And it can be viral, it can be bacterial, or it can be fungal. can be a mixed bag of those things. Sometimes it's caused by allergens, and you just get this fluid influx because of allergies. So there's also non-infectious causes of sinusitis. If it is considered infectious, like from a bacteria, then they'll give you antibiotics to treat it, or antifungals if it's fungal. If it's really bad, they might have to do surgery to drain that fluid. But usually antibiotics can take care of it, or as if it's viral or allergies, it'll be self-limiting, or you take antihistamines. Another common upper respiratory tract infection is otitis media, also known as an ear infection. So it literally means infection of the middle ear, otitis media. So here's the external ear canal here. So it's not talking about an infection in the ear canal, which can happen. That's another type of otitis, otitis externa or something. But otitis media is in here when you get inflammation and fluid buildup in the middle ear, which pushes on the eardrum, and you feel that pressure, and it hurts. And sometimes it's harder to hear because it's all that fluid is in there blocking some of the vibration from sound movement. So this is the eustachian tube here. It actually connects to the back of the pharynx. And so kids are more likely to get otitis media, like infants and toddlers, because the eustachian tube during infancy, so in an adult it's slanted, so there's, gravity helps to pull fluid down, but in an infant it's almost level with the ear, and so it's a lot easier for fluid to get up through the eustachian tube and into the middle ear, just due to the anatomy of the ear when we're very young. And that is part of the evolutionary design for infants, because they drink, their whole diet is drinking, they breastfeed, they have to be able to breathe while drinking, and that actually allows them to breathe while drinking. We can't. Go try it now, get a drink, try to breathe in and out through your nose while you're swallowing. You can't do it, but babies can. So anyway, babies and toddlers much more prone to ear infections than adults and older children. And it can be bacterial, it can be viral. The two bacteria that are the most common causes of otitis media ear infection are Strep pneumoniae, so Streptococcus, really common respiratory bug. Strep pyogenes, pyo means pus, so it causes those white patches in the throat, which I didn't mention. But it also sounds kind of like pyro, think fever and pain, fire, your throat is on fire, okay? And Strep pneumoniae causes respiratory tract, like pneumonia, lower respiratory tract infections, but also can cause ear infection. So most ear infections are really caused by viruses or harmless bacteria that are self-limiting and will get better on their own. So and since it's a really common infection in kids, and we're becoming more and more concerned about giving kids unnecessary doses of antibiotics, what a lot of providers will do now is, instead of prescribing antibiotics for an ear infection, they'll do what's called watchful waiting. So, they'll give you a list of signs and symptoms that if these get worse, call us and we'll do antibiotics. But if it's getting better, we'll just let it resolve itself. And so sometimes there's surgical interventions that can be done if a child is getting ear infections very regularly. They can go to an ear, nose, and throat surgeon who can insert these tubes, these drainage tubes that help to keep fluid out of the ears and reduce the number of infections. Strep pneumoniae and Haemophilus influenza are two organisms that are common causes of ear infections, and there are vaccines for those. So a lot of kids, so vaccination can help reduce ear infections. It definitely doesn't bring it to zero, because again, there's multiple strains of Strep pneumoniae, and Prevnar, which is the vaccine that kids get, only protects against 7 of those strains. So there's still several strains out there that kids can catch ear infections from. So, yeah. Diphtheria. Diphtheria hardly exists anymore because there is a vaccine for that. We'll talk about that in a second. But it used to be a really, really bad disease, but it has been eliminated in the US. There have been no cases in 17 years since 2003. It's 2020 now. And the vaccine coverage is only 83%. That just goes to show that diphtheria is less contagious than something like measles, which needs to have a vaccination rate of like 96, 97%. So diphtheria used to, one of the things about diphtheria is it would cause these really gross like plaques in the throat. I think they were called semi-membranous something or other, and just like really pussy growths in the throat, in the pharynx. And it was potentially deadly. So the vaccine for it is part of the tetanus vaccine. So DTaP and Tdap are vaccines. D stands for diphtheria, T for tetanus, and P for pertussis. So those three things are covered in that vaccine, which is given in childhood and given regularly to boost antibodies, particularly to tetanus and pertussis, which the immunity wanes for those things. All right, an important respiratory pathogen is influenza. Now, influenza is the flu virus, and it's usually cyclical, so it peaks in the winter months and then goes down in the summer months, and it does this year in, year out. Some strains can cause worldwide pandemics, and we've seen this historically. The worst, most recent one was, well, the worst one in recent history was 100 years ago, 1918 Spanish flu. It killed 50 million people worldwide, which was more people than were killed in World War I and World War II combined. It was a huge pandemic, and it's one of the reasons why flu has been so well studied, because a lot of scientific experts really thought that the next global pandemic was gonna be a flu. And it was a little bit surprising to some that it was a coronavirus, which is one that historically has not been problematic. But in recent history, we have seen strains. SARS in 2003 and MERS in 2016, I think it was, were two deadly strains of the coronavirus. So there were some people who saw that writing on the wall and the potential for coronavirus to be the next pandemic. But it was predictable that we had a pandemic coming, because every 100 years or so we do get, and it's usually a respiratory virus. And there are a lot of things that coronavirus and flu have in common that make them both good, strong candidates for causing a pandemic. But the interesting thing about the Spanish flu is this graph here. So normally in a flu season, we see this curve when we're looking at deaths from flu. We get this curve here of most of the deaths are the very young, like infants and small children, and the very old, and people who are maybe middle-aged with comorbidities, like other lung diseases already. But in the 1918 flu, there was this peak here in the middle. It disproportionately killed healthy, young, adolescents and young adults. And a lot of research suggests that this was due to the fact that it caused a really strong inflammatory response in people with strong, healthy immune systems, and that the inflammatory response is what overwhelmed the lungs and killed them. And we're starting to see a similar pattern with COVID-19. It still mostly kills elderly. It seems to be actually least dangerous to young kids. But in this middle age and young adult population, the mechanism of death seems to be similar due to a cytokine storm that's elicited by an overstimulated immune response. And so studying previous pandemics and disease, and certainly having a lot of data from current ones, is going to be really informative in how to treat it moving forward in the future. Okay, so back to influenza. I'm going to kind of keep bringing in coronavirus here, though I don't have any slides specifically about COVID-19. Okay, so influenza usually starts in the upper respiratory tract and then progresses downwards. Usually the symptoms include fever, chills, aches, pains, just feeling really crappy. You may have a sore nose, or sorry, a stuffy nose and a sore throat, have fatigue, but you can also get secondary infections on top of that. So the symptoms of flu can be different in different people. Some people will experience some nausea and vomiting with influenza, but it's totally different than the virus that we call the stomach flu that we'll talk about in the next chapter. Flu is deadly. There's, on average, about 36,000 deaths from flu every year, and that's in like an average year. This year, I think there have been about 100, there's been 100-something thousand deaths from flu globally this year, not in the US, but globally. I think coronavirus just overtook flu in terms of how many deaths there have been, but there were something like 100,000 deaths from flu over the whole flu season this year, and so far the deaths from coronavirus are over about a 3 or 4 month period. The coronavirus season is not over yet, so coronavirus is definitely going to outkill influenza, but influenza is a really serious virus and can be really dangerous to people of all ages. But of course, the very young, like infants, and the very old, like senior citizens, are going to be the most at risk for serious complications. So some of the things that make influenza so dangerous, first of all, it is an RNA virus. It's a segmented RNA virus, and so and it's also very promiscuous. So it can infect lots of different animals. So a single animal could potentially get 2 different strains of flu, and then those 2 strains of flu, when they are inside of a cell replicating, they can mix and match pieces of their DNA. And then what you end up with is a whole new strain of flu. And so flu mutates very quickly because of this. And that's why we have to have a flu shot every year. They make a new flu shot every season to different strains of flu that they think are going to be the ones most in circulation that year. The the antigens that we really design our flu shots to are these surface antigens. Here, the H and N groups, the hemagglutinin and the neuraminidase. These are the spikes that stick off the virus, and they are also the spikes that recognize and fuse to respiratory cells of the respiratory tract, and infect. And they are ones that mutate most frequently. And so just, even throughout the flu season, the strain that's circulating at the start of flu season in October could be totally different than the one that's circulating in April because of mutations that the virus undergoes during that time. And then the pandemic strains of flu are caused when basically one organism gets infected with 2 totally different strains of flu, and you get some mixing and matching. And so there were a few years ago, we had an avian flu, and then we had a swine flu outbreak. So those were strains of flu that had potentially formed in a bird or in a pig because they were very similar to species, to flu strains that were common in birds. And what happened was a bird probably got infected with a human strain and a bird strain, and it mixed and matched and then jumped the species barrier. And so it contained a lot of new antigens that nobody had immunity to, and that's why it was particularly bad. So those are some of the important things to know about the structure of flu. There are different strains of flu, A, B, and C. So you might hear people talk about like, oh, I'm positive for influenza A or influenza B. And that's important for tracking these different viruses and tracking the different virulence of them. So like I said, viruses can change. The flu virus is very talented at mutating. And so there's these changes in DNA, these mutations, we can say are due to either shift or drift. Now I put this is backwards. I should change this slide. But on the left here is showing us drift, antigenic drift. drifting, like think of yourself in a boat and you're drifting along, you're just slowly moving, okay? So a drift, genetic drift is slow changes that are due to mutations during replication that make slight changes in the H and N molecules, spike proteins on the surface. So these are slight changes that occur basically every time the virus replicates. Shift is like a big jump, a big change. And shift is what happens when two different strains of the virus get into one cell and then swap parts. So let's say you have a duck influenza virus and a human influenza virus, and they both get into a pig. And as they're replicating, they get a little mixed and matched, and one piece of the duck influenza virus, one of the RNA pieces, gets replaces one of the human influenza virus pieces. And so now you have this new sort of hybrid virus that is very different. It's not just slightly different, but very different. So those are tend to be particularly bad in terms of their effects on human health because, again, they're so new that nobody has natural immunity to it. So antigenic drift and shift are just characterized here on this slide. Shift is due to exchange, sort of swapping of pieces of DNA between different viruses, and antigenic drift is due to slight changes that's due just to errors in replication. Some of the virulence factors that I already discussed with influenza, the hemagglutinin and neuraminidase, those spike proteins, are important for binding to the cell receptors and then breaking down mucus of the respiratory tract and getting into those cells. Another thing that can be dangerous with flu is that it can cause severe inflammation and irritation to the lungs, which is what actually can kill you. Not the virus itself, but the inflammation that it elicits. And that's one of the things that we think happened with the 1918 flu. We don't have that data, but there have been researchers that have actually dug up bodies and isolated 1918 flu virus RNA and have grown it in the lab and then tested it in animals and have shown that that has been something that happened. The 2009 outbreak of H1N1, which I think was avian flu, also was doing that. So causing massive cytokine storm, which was dangerous. And it's also, we think, happening in coronavirus, some coronavirus patients. So how do we diagnose flu? Sometimes it's just based on symptoms. A lot of times doctors will just do it based on symptoms alone. If a flu kit is not available to do flu testing or if they are pretty positive. Sometimes these things are reported as flu-like illness. So when somebody reports with symptoms but they're not actually tested for flu, when that is reported to public health associations, that's oftentimes reported as flu-like illness. So it will often go into the flu counts, but they will separate the flu counts based on those that were tested positive versus those that were suspected positive. There's also rapid flu tests. Again, that sort of dipstick. One line is negative, 2 lines is positive. There's ELISAs, but the rapid test is the one that's pretty commonly done. There is prevention for influenza. There is a vaccine. It's available every year. It is redesigned every year. It's designed to be effective against 3 strains of influenza, and those 3 strains are determined by a team of influenza biologists who basically are predicting, using mathematical models, which strains of flu they think will be most in circulation that season, and that's what the flu vaccine is designed towards, 3 strains. So it's not 100% effective. In terms of vaccines that we have, it's probably the least effective vaccine in that, plenty of people who get vaccinated still get the flu. But it is our best protection that we have against flu. There are some medications, but they're not all that effective. They're not any more effective than vaccination. They're probably less effective than vaccination. And so there is a lot of research, though, into trying to So the vaccine right now really targets those H and N proteins on the surface, those spike proteins, which we know mutate and change. And so there is a lot of research right now trying to figure out how to design a universal influenza vaccine, to maybe find an antigen on the surface of flu that doesn't mutate so regularly and that's more constant across all strains of flu. That would be a better antigen to design the flu vaccine for. So there's definitely a lot of research going into that, and hopefully we'll see that in our lifetimes, a much more effective flu vaccine. So it's not a perfect vaccine, but it is the best defense we have. So it is important to get the flu shot and try to protect yourself and therefore people around you from the flu. It's an inactivated vaccine, by the way, so it's killed virus. There was a live attenuated vaccine that was flu mist that they would squirt up your nose, which was thought to be more effective because the virus actually would replicate and you actually kind of got some flu-like symptoms a little bit. It made you feel a little bit crappier. But then they reformulated it, and when they reformulated it, they found that they killed the efficacy. So it was no longer effective. So they had to take it back to the bench and do some more work on it before they can re-release it again. So we might get that one back. It was nice to not have to get a shot for a couple of years. But most of the vaccines for flu are grown in eggs. The virus is grown in eggs. And there are a handful there's also a subset of recombinant vaccines that are grown in bacteria that are given to people with egg allergies, just in case there's any egg protein left. There shouldn't be, they're purified, but sometimes, a little bit of egg protein is left in there. So if you have an egg allergy, you definitely want to let your whoever's giving you your flu shot know, though it is one of the required questions that they ask beforehand. The treatments for influenza. So there are different drug classes. Tamiflu is one that's gotten a lot of press. There's a lot of resistance being seen to Tamiflu. Tamiflu is more often given now as almost a prophylactic. So if somebody in the house tests positive for influenza, they might put other family members on Tamiflu as a preventative to prevent people from getting influenza from confirmed patients. But a lot of these drugs are only so effective in severe cases of influenza. They work best if they're given at the beginning of the disease. They really have to be taken early in infection to have an effect. Once you get to severe disease, it's too late for any of these drugs to work. So we're still, not great at treating flu. Alrighty, the next respiratory infection that's also vaccine preventable is whooping cough, also known as pertussis. It's caused by a bacteria called Bordetella pertussis, and it causes this cough that has a really distinctive sound. So this is different cough sounds. If I can get this to work, it's a video.
Business idea needs a website? So go to Wix.com. I know what you're thinking.
One of the best ways to diagnose a cough, and the way we do it, is by listening. So let's listen to this cough.
That's a pretty severe cough, and one clue I hear is that the child's coughing, doesn't breathe in, and then coughs a couple more times, and that's kind of a clue to whooping cough or pertussis. And with that, you get those long coughing spells. It's pretty serious in babies. The problem is the child can't breathe because they're coughing so hard, and sometimes there'll be a little whoop at the end of the coughing spell, a little as they're gasping for breath to get that oxygen back in, and that's one of the reasons it's so dangerous. The children aren't getting oxygen to their brains.
Vaccination.
Sure, there's a vaccine against this one, so I don't see it nearly as much, thank God. So here's another type of cough. I actually hear this one over the phone a lot. And that's a very croupy, kind of barky cough or breathing. And this one's caused by a virus. Sometimes it's the same virus that causes colds or laryngitis in older people, but it causes a swelling of the vocal cords, and you have a hard time breathing in like that. And this one tends to get worse at night, so the child kind of wakes up with the barky cough. The thing to do is put them in the hot, steamy shower, because that steam, that moist air can really help it.
Like a
This
croup
is-
tent.
yeah.
croup tent.
And the good news is that steroids can
Yep.
tamper down that a little
Yeah.
bit if need
Yeah.
be. Luckily, a lot of times it just improves on its own. Well,
Mhm.
listen to this one. I'm sure you've heard it. So that's a dry cough. The causes of a dry cough are a little bit different than the causes of a wet cough. Things like asthma. Believe it or not, influenza typically presents with a dry cough. Tuberculosis, some pneumonias, depending upon what kind of pneumonia can be a dry cough. You know, and a lot of times it can just be irritants. You know, if you're getting back to asthma, dry cough, if you're entering an environment where there's a lot of pollutants, you can get irritation, and that's your response is to cough. But there's nothing to cough up, as opposed to this type of cough.
You're coughing something up here.
You know, you can have a wet cough just from postnasal drip, from bronchitis, from pneumonia. Just the regular old cold gives you some of that wetness in the cough because, again, all that junk in your nasal passages, it goes back into your throat, into your airways. You're coughing it up. But those coughs, I really think the question of whether or not you go see a doctor or a specialist comes down to how do you feel?
Yeah.
How long is it going on?
All right, apparently that's the end of that video. So, the cough sound that you get with whooping cough with pertussis is definitely very characteristic. That whoop where it's like cough, 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 like is very telling. And so sometimes can be even diagnosed over the phone. Like they said, they can hear, people will call in. Or if you have an infant, a good idea if they have a cough, especially if they're coughing a lot at night, is to like use your phone or something to record the cough sound. Because when you take your kid in to the doctor's office, or even for yourself, when you go in, you don't always have the cough. You can't always induce that cough sound. And so having a recording of it can be really helpful for doctors because they can actually do some diagnosis based on the sound of a cough. So pertussis is less common because of vaccination. It's part of that DTaP, the diphtheria, tetanus, pertussis shot. So it is much less common, but we do still get outbreaks of it because of those dropping vaccination rates. And you do get waning immunity. So immunity doesn't last for your whole life. You do need to get boosters every 10 years of the DTaP vaccine, particularly to boost your immunity to tetanus and pertussis. So any any new parent should get it to protect their infant, and also like anyone who's visiting. So I know a lot of people who won't let the baby's grandparents come if they won't get a DTaP booster shot. That they even make the grandparents do that, and aunts and uncles and stuff like that. So it's good to stay up to date on that to protect yourself from tetanus and potential pertussis, but especially to protect infants around you from it, because even if you've been vaccinated, that immunity wanes over time. It's not forever. So outbreaks can happen not necessarily because people are anti-vax and completely unvaccinated, but they can happen when people's immunity wears off over time and they haven't had those boosters. So having new babies in your life can be a good sort of reminder or incentive to get up to date, because a lot of adults don't keep track, and even general practitioners don't necessarily keep track. So it's a good reminder to get a booster. All right, another virus that can cause really serious respiratory infections, particularly in infants, is RSV, respiratory syncytial virus. And it is really common in little babies. It's most dangerous for premature babies and children that are 6 months or younger. There is no vaccine for it currently, but there are vaccines in clinical trials. So hopefully we will have a vaccine for RSV really soon. Probably a lot of you have experienced it with kids or have known people who have experienced it. It's very scary. They have a very hard time breathing, and some babies need to be hospitalized and some babies die from it. But it's definitely a very scary infection to have. It's called respiratory syncytial virus because of one of the virulence factors is it causes the formation of syncytia, which if you remember from early on, it's when a bunch of cells kind of stick together and form a giant cell in the respiratory tract. So there's the prevention really is just, try to keep babies away from people as much as you can and germs. But for kids who get really bad infections, the only treatment we really have available, there's no antivirals for it, but they can use antibodies, inject antibodies, anti-RSV antibodies to try to help. But again, sometimes the damage can be too great. Another bad respiratory infection, it's caused by a bacteria, is tuberculosis, which is often just referred to as TB. And it's a bacteria called Mycobacterium tuberculosis. It's not a gram-positive or gram-negative bacteria. It's an acid-fast bacteria, so it's a different staining procedure. I'm going to sneeze. Excuse me. I didn't even do that on purpose for a respiratory chapter. If only I could just elicit a sneeze on cue. Anyway, tuberculosis is a pretty ancient pathogen. It's caused disease for ages. I don't know how many years. I'm terrible with dates, but it's gone through several names throughout history. So it's been called the White Plague. It's been called consumption. It's another really common form for it because people who have it, they cough a lot, but they also tend to lose a lot of weight. And so it consumes you, basically, so the consumption. They also tend to get very pale and white, so the White Plague. And we think of it as something that has largely gone away. You probably don't know anyone who has tuberculosis. It's not a common infection in the US, but it is still a huge problem globally. And the other thing about tuberculosis is it can have asymptomatic periods. So people can be infected and not know it, which is why healthcare professionals, when they work at a healthcare facility, they have to be regularly tested for TB because they could have it and be asymptomatic. And it's pretty contagious and it can be very deadly. Most of the cases of tuberculosis are in the lungs. It is 85% of the time a respiratory infection. But there are other forms of tuberculosis where it can infect other body systems that are much less commonly heard of. So this is what tuberculosis looks like and where it gets its name from. All right, so it can start out as a little infectious node here and then spread throughout the lungs. And the bacteria can form these tubercles, these sort of masses, and they can go dormant for a while in the lung. So that's where it gets the name tuberculosis. And another virulence factor that it has is it has the ability to replicate inside white blood cells, macrophages. So it gets into the lung tissue, macrophage engulfs it, but instead of killing it, it just keeps replicating inside the macrophage. And then it can form these tubercles, these sort of walled off areas in the lung where the bacteria is replicating inside that. And then those tubercles can also become active and spread throughout the lung. So it can spread slowly, it can spread quickly, it can be asymptomatic, it can be symptomatic. So when tuberculosis reactivates, when those tubercles go from being dormant to being active, they can cause those severe symptoms that we associate with tuberculosis, with the White Plague and with consumption. You get chest pain, violent coughing spells. A lot of times you'll get bloody sputum. One of my favorite movies when I was in college was Moulin Rouge, and Nicole Kidman's character, they never say it, but she's got tuberculosis. She's always coughing into a rag and there's blood spots. She's also very thin and pale. And those are also signs of tuberculosis. If you have tuberculosis and you don't treat it, there's a very high mortality rate. But even with treatment, it can be fatal. And the treatment is pretty tough regimen. But I'm just going to, before I talk about treatment, talk about other forms of tuberculosis. So again, like 85% of the time, it's it's an infection in the lungs and the respiratory tract. But there are rare cases where you can have tuberculosis of the intestines, or tuberculosis of the ovaries, or tuberculosis of the kidneys and the bladder. Those are really uncommon. But if you're a Grey's Anatomy fan, I don't remember what season it is, but there is a season where they have a patient, they open him up on the table and realize he has tuberculosis of the intestine, which was not expected. So again, probably more common. If you've traveled to foreign countries where tuberculosis is more of a problem, or you live in a country where it's more of a problem, in the US, it's the number of cases we get are primarily in people who travel. There's actually a lot more cases in the US than people realize. There were 1.3 million people who died in 2013, so that's a kind of dated number. I should update this, sorry. But 60% most of the US cases are people who were born elsewhere or traveled elsewhere. So usually they acquire it elsewhere and not in the US. The biggest risk, of course, will be people in countries where it's more endemic, and people who have underlying problems with their health, inadequate nutrition, poor immune system. So people in lower socioeconomic classes are more susceptible and prone to tuberculosis, and that's true in developed countries and, of course, undeveloped countries. The diagnosis of tuberculosis is based on the PPD test. So it's an injection of purified protein derivative from Mycobacterium tuberculosis under the skin, and then you wait for that type 4 hypersensitive reaction to read it. If there's a large bump and they measure it, if it's larger than a certain size, then that means that you test positive, you're having a positive reaction. That may just mean that you were somehow exposed but never got infected, or sometimes there's other mycobacterium that live in the soil that you can be exposed to that cause a positive result. So there are false positives. And so the next step is to have a chest x-ray and to look for an area of infection, of cloudiness. So that would be done to confirm a positive PPD test. There's also blood testing that can be done looking for antibodies towards tuberculosis. You can culture sputum, like if somebody who has an active case of suspected tuberculosis, you can culture the sputum and do an acid-fast stain to look for mycobacterium. The way to prevent it, there is actually a vaccine. It's called the BCG vaccine, and it is to a different strain of mycobacterium, not Mycobacterium tuberculosis, but another strain of mycobacterium so it's kind of like the smallpox vaccine, where we use cowpox. And it's not commonly given in the US except to people who are maybe at-risk populations, but it is commonly given in a lot of other countries as part of like the regular vaccine schedule if tuberculosis is a major health threat in those countries. And the problem with vaccinating is then it kind of disrupts the ability to test people, because if you've been vaccinated, then you will have a positive response to the PPD test. So they'll have to do a chest x-ray. So it's one of the reasons why we don't vaccinate people in the US, because it's fairly uncommon, and the way that we monitor cases would be foiled by vaccinating people. But an interesting thing related to coronavirus is that there is a correlation in countries that regularly do the TB vaccine. They're seeing fewer deaths from coronavirus, and they're wondering if that's a meaningful correlation. So they're actually doing trials in the Netherlands and in Australia. They're giving healthcare workers the tuberculosis vaccine to see if it reduces, first of all, disease from coronavirus and also death from coronavirus. So the BCG vaccine apparently boosts innate immunity as one of its side effects. And innate immunity is really important for clearing the coronavirus and preventing it from getting to that severe stage. So while it may not protect people from infection with coronavirus, it may have a protective effect against severe disease from coronavirus, which would be a huge boon. So I'm keeping my eye on those trials, because that's a vaccine we already have that we could put into use potentially and save a lot of lives and protect a lot of people until we have an actual vaccine for the coronavirus. So tuberculosis being very, very contagious, people who have tuberculosis or test positive for tuberculosis, they have to be put in negative pressure isolation rooms to prevent the spread of tuberculosis through air particles. And there are antibiotics to treat tuberculosis. The problem is that patients have to be on them for anywhere from 2 months to a year. And they oftentimes have, unpleasant side effects, give you diarrhea or whatnot. And so what happens is patients are taking these antibiotics and then they're like, oh, I feel fine. I don't feel like I have tuberculosis and I'm tired of the diarrhea from the antibiotics, so I'm just going to stop taking my antibiotics. Or they can't afford a year's worth of antibiotics, or so for whatever reason, or they're just like too lazy to continue them. And so non-compliance with antibiotic therapy is a huge problem in treating tuberculosis, but it's also given rise to a bigger problem, which is antibiotic resistant tuberculosis. MDR-TB is multi-drug resistant tuberculosis because, of course, low levels of exposure to antibiotics, not finishing your antibiotics, is a cause of antibiotic resistance. So these multi-drug resistant tuberculosis is a huge threat, the World Health Organization, because it really prevents us from keeping TB under control. And it's largely due to poor compliance by patients. You can't hospitalize them. You don't need to hospitalize them for 2 years and keep them on drugs. That's something that's their responsibility to take on their own. And so there's a lot of outreach for people who are TB patients, for, like nurses calling them regularly, are you taking your medications, to try to keep them compliant. But really that's a major cause of these drug-resistant strains. All right, pneumonia. Pneumonia is a disease. Basically, it's fluid in the lungs. So it's an anatomical diagnosis. It's just any time you have fluid in the lungs. So there can be pneumonia that is organic, caused by some inflammation, could be, but a lot of times it is infectious. It's triggered by an infectious agent. So there's a ton of different microbes that can cause pneumonia. Viruses, bacteria, fungi, all right. Pneumonia is a big killer in terms of respiratory diseases because fluid in the lungs cannot be effectively removed or drained, and it's when those alveoli start to fill with fluid, which then makes it hard for you to get enough air into them to do gas exchange. Sometimes that fluid can prevent the alveoli from opening and closing properly. And so that's really what is deadly in a lot of these viruses and bacteria of the respiratory tract, is when they lead to pneumonia. In the US, if we don't count COVID patients right now, on average, we have 2 to 3 million cases of pneumonia a year and 45,000 deaths per year from pneumonia. So some of the causative agents that can cause pneumonia: Streptococcus pneumoniae, the pneumococcus, all right, most of the cases of 40% of cases of pneumonia are from strep pneumoniae. So it can also be a secondary cause of pneumonia. People with like viruses like flu can acquire pneumonia from secondary infection with pneumococcus. The good thing is that there are vaccines available, so that reduces the number of cases, but it's not in any way going to eradicate or eliminate it because there's just too many strains of strep pneumonia out there. Haemophilus influenza can cause pneumonia, though that is not really a major cause anymore because the vaccine has been so effective at wiping out Hib. Another one that's kind of a fun story is Legionella, or it leads to disease. Legionella is the bacteria. The disease is called Legionnaire's disease. So Legionnaire's disease was discovered, I don't know the year, in the last century, sometime in the, 1980s, maybe 1970s, in Philadelphia at a hotel. There was an American Legion convention, which is like for veterans, And so it was a lot of older Americans in this hotel, and a whole bunch of them came down with pneumonia. So of course the epidemiologists come in and they're like, this is weird, it's not flu, it's not pneumococcus. What is the disease agent? And they found it was this new novel bacteria. They named it Legionella after the American Legion, and they called the disease Legionnaire's disease. And it turned out it was a bacteria that was contaminating the air conditioning system because it was a bacteria that came from like bird poop. And so pigeons were like pooping on the roof and where the AC coolant fluid was. And so then the AC coolant was contaminated with this bird poop, and then it was being aerosolized throughout the hotel. And so it's somewhat opportunistic. So it really only caused disease in people who were elderly and slightly immunocompromised because of that. But it is a pathogen that can cause disease. Now it's more widely known because of that one outbreak. They really identified it. There's some others on here. A lot of these are more mild. So some of these here, Mycoplasma pneumoniae and Chlamydophila pneumoniae, are what cause what we call walking pneumonia, so like a less severe case of pneumonia that people are not hospitalized for. There are some fungi that can cause pneumonia, but they're usually opportunistic. Hantavirus is a very deadly one that can be caused when you go hiking or something, you step on mouse droppings. Mice can carry this virus, and you step on the mouse droppings and then that aerosolizes them and you inhale them. It's pretty rare, like this hardly ever happens, but when it does, it has a really high mortality. And then of course there's tons of viruses that can cause pneumonia. The viral pneumonia is usually more mild than bacterial pneumonia, except for cases like novel viruses or really bad viruses like influenza or coronavirus. So I do have a slide here on SARS and MERS. So these are emerging coronaviruses. So this slideshow, sorry, is a little bit dated. So when I made this was before coronavirus, and already the epidemiology, the microbiology community was aware of these new emerging coronaviruses that go beyond the common cold and cause deadly pneumonia. And now here we are in a global pandemic of the newest strain, which has made it around the world and is in fact causing deadly pneumonia in hundreds of thousands of people. So some healthcare associated pneumonias, these are ones that are common causes of nosocomial infections, which is fairly common for people to acquire because they might be intubated or be on ventilators and have things stuck down there, or nasogastric tube or something that ends up introducing bacteria into the respiratory system. Pseudomonas aeruginosa is what was normally a pretty normal flora, all right, but can cause a lot of hospital-acquired cases of pneumonia. Acinetobacter baumannii is an emerging pathogen because it can become resistant to antibiotics really easily. Acinetobacter are naturally competent cells, so they can pick up DNA easily from their surroundings. So although it was not a pathogen for a long time, it's now becoming a problem because it's antibiotic resistant. Strep pneumonia, Klebsiella pneumoniae, also another one that's becoming very drug resistant. So a lot of these nosocomial causes of pneumonia are concerning because a lot of them are drug resistant forms, and that makes it much harder to treat. There was a Dateline episode on this deadly Klebsiella pneumoniae that was spreading through hospital wards and just killing everyone in the ICU units, and pretty scary. So the mortality rate of these is much higher than community-acquired pneumonia, particularly because the people who acquire it in the hospital are oftentimes already, immunocompromised or injured or weak in some way, and B, a lot of these strains end up being drug resistant because, again, in a hospital you have lots of people on antibiotics, and that's where you get evolution of a lot of these drug resistant strains in hospital patients. And then of course they can transfer them. So this is just talking about how mechanical ventilation can introduce organisms into the respiratory tract of hospitalized patients. That proper treatment is to prevent by making sure everything is sterile. Sterile field when you intubate, making sure all the equipment is sterile, and then of course starting treatment as soon as possible when a case comes up. And that is the end of chapter 19. Thanks for watching.